Good evening to everyone who has joined. You might have overheard. I am post call, but I promise you this is going to be a great webinar, and Dr. Clark is going to do most of the talking. Um, this is one of our Seven Starling webinar series designed to give you, healthcare providers across specialties, pearls to help you feel more confident in supporting your patients with mood and anxiety disorders across the reproductive lifespan. Um, and I'm Dr. Nazanin Homafar. I'm a board certified OB-GYN practicing in Northern Virginia and the medical director at Seven Starling. Seven Starling is a virtual mental health clinic that treats those experiencing anxiety, depression, and trauma through fertility challenges, pregnancy loss, miscarriage, abortion, and postpartum. I'm honored to be joined by Dr. Crystal Clark. She is an associate professor of psychiatry at the University of Toronto. She's in Toronto now with that background, and I don't think I could have ever imagined it. And is also the associate head of research at Women's College Hospital. She's dedicated her career to reproductive psychiatry and the advancement of maternal mental health as a research educator, clinician, and thought leader, and also as an advisor to Seven Starling. Today, we're talking about PMDD, or premenstrual dysphoric disorder, and diving deeper into the diagnosis and management of this condition. Welcome, Dr. Clark.
Well, thanks for having me, Dr. Homafar. And as usual, I look forward to these discussions every month that we do them. And so, yeah, I think we have a great topic tonight.
Yeah, and lots to cover. And I always think we're going to have enough time, and we don't. So I want to just jump right in. Can you start off by telling us what is PMDD? How does it compare to PMS? And then
Mhm.
we can talk about the causes and how common it is.
Yeah, so PMS being premenstrual symptoms versus PMDD being a premenstrual dysphoric disorder. Really, PMDD is just a severe form of PMS. It's just severe symptoms of PMS, such that they can be debilitating, impact your daily function, very uncomfortable. Um, Maybe people have severe enough symptoms where they're feeling suicidal or something like that. That would be PMS symptoms that are severe enough to be in the range of PMDD.
And how do we know what causes it?
Yeah, I mean, there are definitely at least some theories around the mechanism. So the change in hormones during the luteal phase, what we know is that progesterone and its metabolite allo rise, and that change in exposure from it increasing and then rapidly decreasing right before the menstruation cycle or menses is thought to be the reason that you have this onset of symptoms. Those who are sensitive to that withdrawal of the progesterone in the allo. So often we're seeing symptoms like 3 to 4 days before the menstruation starts. The most severe symptoms are around that time, and that's when you're seeing that switch, that rapid withdrawal from the significant exposure to the aloe and progesterone.
And I know we talk about malignal symptoms as OB-GYN, so breast tenderness, acne, mood swings. What would you say are the symptoms of PMDD?
Yeah, so PMDD really constitutes two categories of symptoms. One, you have a major affective component to the symptoms, so that could either be severe irritability, very depressed mood, high anxiety. So there's a strong affective component. And then there's a secondary component that's more the affective cognitive component. So that's where you have changes in sleep and appetite, difficulty concentrating, lack of interest, and those types of symptoms. And usually need to have five, by the way.
Okay, yeah, can you tell us what are the criteria for diagnosing PMDD and how does one differentiate it from really bad PMS?
Yeah, so diagnosing PMDD really is about really tracking the mood and having a consistent pattern of these symptoms happening during the luteal phase and remitting during menstruation. And it should be pretty like clockwork, like, every 5 days before the period, and with some variation from person to person. And then maybe 1 or 2 days after the period starts, like, oh, I'm feeling completely better. Um, how it's diagnosed according to DSM-5 is you again have to have at least one major affective component, and then uh, and you can have several, but then at least another four symptoms along with that are debilitating during that time and that have a consistent pattern, have consistently been that way for the past year. So it's not just like, oh, it's that way for 1 month. And really, what we do to diagnosis is to look at the past couple of cycles and see how the symptoms were during those last two cycles. And, it's diagnostic if the symptoms have been consistent.
And I'm not sure with our audience, their familiarity, but just a reminder in case people don't know the different phases. You have the follicular phase and the luteal phase in the menstrual cycle. The follicular phase starts with the first day of the menstrual cycle, all the way right up to ovulation. And the luteal phase is characterized by ovulation all the way up to the first day of the menstrual cycle. So when you're talking about the luteal phase, you're talking about that time from ovulation until the beginning of the
Right,
menstrual cycle. And
exactly.
then I think you mentioned DSM-5, and I know ACOG also uses a definition where they say at least one symptom is associated with economic or social dysfunction that occurs during the 5 days before the onset of menses, and they say is present in at least 3 consecutive menstrual cycles. Um, what I thought was interesting, or one thing that I didn't realize before, are that you can give your patient almost like a chart
Mhm.
to map out their mood and physical symptoms, so you can see exactly when these symptoms are starting and when they're finally alleviated, to help the patient get a better sense of whether or not it's truly PMDD.
Yeah, yeah. And that's what's recommended. If someone is, at least in the clinic where I'm at, for instance, if someone is complaining of the possibility of having PMDD, before they even come in, we have them complete 2 to 3 months of rating their mood with a chart, McMaster chart. There's several out there, but there's several validated charts, and they do that and bring that in. Or if it's your first time meeting them, they're complaining of that, have them do that, come back in 3 months with those charts, and and then it's easier to assess whether or not they're really having PMDD, or they're confusing this with the underlying mood disorder or anxiety disorder that's just getting worse around their period.
Mm, true, because there's always that possibility as well.
Yes.
So is it truly, so it is, charting is the validated tool? There's no survey or questionnaire like we
Mhm.
have with the EPDS or PHQ-9. Okay,
Yeah.
the chart is the way to go.
Yeah, chart is the way, because you really want to see each day of the month. And the reason for that, again, is often people will confuse it with having depression or anxiety that might be mild throughout the month and then increases significantly in the luteal phase. And what I mean by that is that, like, I saw someone today, and there's X's all over the place in terms of their mood throughout the month, and yeah, they're definitely consistent before the period, but it's also after the period. And, it's like it's never really gone. I'm like, that's a little different than, 5 days every time before the period, or 7 days right before the period. So that chart means a lot. Whereas a survey will get a cross-sectional snapshot. And if you say, is your mood worse? Do you have these symptoms right before your period? Everyone's going to say, yeah.
Yeah,
Um, it's hard to tease out whether or not, or what's going on the rest of the month. Yeah.
that's a really good point. And I think just want to point out too, in terms of how common it is,
Mhm.
um, do you have a sense of, PMS? I feel like we always talk about, everyone has
Mhm.
a general sense, but what's the prevalence of PMDD?
Yeah. So depending on what study you're looking at, or what prevalence epidemiology study you're looking at, it's anywhere between 2 and 10%.
Right.
Most commonly, you'll see probably 3 to 8%, but yeah, some studies say as low as 2, some as high as 10. And this is variable depending on geographic location, culture, ethnicity. It seems to vary by those factors.
That, I also, in anticipation of this webinar, I saw this wonderful comic on the Washington Post about PMDD. I don't know if I can share it with everyone, but I think for me it was just an acknowledgement that more and more people are talking about it and wanting to understand it. I put that in the chat in case anyone
Mhm.
wants to look at it. So let's transition to talking about management options,
Mhm.
because we know, well, I'd love to hear from you the pharmacologic versus non-pharmacologic management options for PMDD specifically.
Yeah, so the body of non-pharmacologic, I'll say, is definitely growing, and is very different than the pharmacologic for lots of reasons. But I would offer that this is a very biological disorder. This is not like, I don't know, I got stressed out and I just had PMDD. It's very much, not that depression isn't as well, but we can target and identify the hormones that are changing and what's happening. And so medications definitely increasingly are targeting that mechanism. So pharmacotherapy, SSRIs are the gold standard. Um, now, with that said, they do not treat everyone the same, just like they don't for depression, but they are the gold standard. And then non-pharmacologic treatment can include anything from aerobic exercise, supplements like magnesium and calcium, B12, and also psychotherapy such as CBT and mindfulness. And what's happening with CBT and mindfulness is really coping. It's not treating, which is why I say pharmacology is very different because it's actually treating it. Uh, the to remit the symptoms, the psychotherapy and some of these other non or alternative treatments are more so helping you cope. It's like, okay, if I can just, you know, accept this, think about it differently, reframe it in my brain. Maybe the calcium will help a little bit more. The aerobic exercise will, make it a little less severe. Acupuncture is something that some people swear by. I would actually say that's probably more of a treatment in terms of getting at the mechanism, like inflammation and things like that. Um, but yeah, that.
And you mentioned SSRIs. How about birth control or ovulation suppression? Is that something that, are you ever prescribing that, or should I bring in what I do as an OB-GYN?
Yeah, feel free to bring in what you do. So I will tell you, I didn't bring up oral contraceptives, although we know gesperinone, the combination pill with gesperinone, ethinyl, estradiol is the go-to. Yaz was really big for a while. It's like, oh, give Yaz. But the reality is a lot of people don't respond to that, and some symptoms get worse. So it's really, the evidence around it is very hit or miss. There's a lot of placebo. Activity there. It has not shown to consistently be better than placebo. And so you have, yeah, hey, but if placebo works, I'm like, hey, if you got better, whether it's placebo or
Usually
not, that's
doesn't work more than 3 months, though,
right,
right?
right.
It starts wearing off.
Yeah. So even, skipping the, placebo week with the oral contraceptive, for some people it will work. It's definitely worth a try, but I wouldn't be surprised, when people come back. And I do prescribe it sometimes. I definitely am happy to refer people to their OB-GYN though, to prescribe it as well.
And I remember there was a big paper last year, and this is what helped me, or in the past 2 years, that showed for PMDD, SSRIs are more effective than birth control or ovulation suppression. But for some patients for whom contraception, the way I usually think about it is for people for whom contraception is important and they also have PMDD, then we
Mhm.
can think about trialing a combined oral contraceptive. And as you mentioned, the best, I think, if it is going to be effective, that combination of ethinyl estradiol, so having at least 20 micrograms of it, plus
Mhm.
drospirenone for that combination of Yaz, which is a very safe combination, by the way. I know that there were some studies about blood increased risk of blood clots with drospirenone, and that has that data is weak, but that would be the best, or continuous administration of pills that have at least 20 micrograms of ethinyl estradiol and 90 micrograms of levonorgestrel.
Yeah.
Progestin alone, which we use for progestogens alone, which we use for ovulation suppression, are not going to be what you want to use for someone who has PMDD.
Absolutely agree with that. And I would add, when you're using an SSRI, it's low dose. I mean, it's not a I don't know if you were going to ask about this, but it's not a for sertraline, we start at 25 milligrams. If it doesn't work, well, 25 go to 50, but we're not likely getting to high doses like 150 and 200 for PMDD.
And yeah, I would love to get into, because I want providers to leave this webinar and know how to prescribe some of those SSRIs. I remember it kind of blew my mind that for PMDD, you have three options. You can either give daily SSRIs or do luteal phase SSRIs. So just 2 weeks of SSRIs from the time of ovulation to the beginning of menses, maybe a few days extending into menses if people are having symptoms there, or symptom only treatment. So, can you explain the rationale behind the use of SSRIs in these different ways when we know for mental health outside of this, you really do
Yeah.
have to take something daily?
Yeah, so it really goes back to the mechanism to which we believe is causing PMDD in the first place. So, if you're taking a SSRI, we believe that it's increasing your allo formation, and by doing so, that increasing those levels, it's treating the PMDD, reducing the symptoms. Because some of what we believe is going on is there is a lack of, almost like there's a tolerance to the allo. So meaning that you're not getting the benefits when it is there because there's either a tolerance or there's not enough, and then it's dropping off, like I said. So then there's low amounts. You have that withdrawal right before the menses. So you're increasing those levels. And serotonin does that. The SSRIs do that immediately. It does that within days. And so just having that increase treats it versus major depressive disorder, which is there's many mechanisms in which we believe is going on there, but different than just the aloe and progesterone.
So, how would you think about who you give daily SSRI versus intermittent versus luteal phase versus symptom?
Yeah, yeah, it really comes down to, it's very personalized, and comes down to what is working best for the person. You can start with spot dosing. That's what most patients are going to want because they want to believe that they don't need to take this every day, and maybe they don't, and no one wants the burden of that anyway. And so they're going to want spot dosing or take it when their symptoms onset, and if that's enough, then great. But you will find some patients are, they actually do experience some type of withdrawal from stopping the medication, or they actually start to realize that actually I'm quite symptomatic. I feel the symptoms so much more when I stop this than when I'm taking it. So they're the type of patients where I'm thinking they need to take it all month. And usually the ones that need to take it all month, I find more often than not, again, have underlying anxiety or depressive disorder.
And I'm thinking of the patient you mentioned on their chart where you're seeing those symptoms a little bit. Maybe they're not having them as they're not as exacerbated in their luteal phase, outside of
Yeah.
their luteal phase, but that might be the person for more continuous. Um,
Yeah.
versus, yeah, the luteal and symptom treatment, or the spot treatment. Would
Mhm.
you Are you thinking about, can you give us an example of some regimens you use, and if you're doing luteal phase or symptom treatment only, are you using higher doses of SSRIs in those cases?
No, still using low doses. And really any SSRI will work, but the ones that have been most studied for this are Prozac, escitalopram. Paxil, sertraline. So any of those, starting at a low dose, of course, titrating up if it doesn't, if say you're using Lexapro or escitalopram, so you start at 5, which is below a therapeutic dose. Maybe that helps somebody, maybe it doesn't. You go up to 10 the next month. You just titrate it to effect. But those are the main 4 that have the most data, but any SSRI is appropriate.
And what I'm hearing from you is that you're saying for one cycle, use a set dose. And if you didn't see an improvement, increase it for the next. You're not increasing the dosage within the same cycle.
Exactly.
Okay.
Exactly.
Okay. So you could do that with any. Are there
Hmm.
any SSRIs or SNRIs that should be avoided?
No, no, I would say that the SNRIs have not been as well studied in this regard. So I would definitely stick to starting with SSRIs, and if one SSRI doesn't work, going to another SSRI and then in the next cycle. After, of course, after you have tried for several months, getting it up to a dose that's, effective. But SNRIs, not that they can't be tried, but it should be like you've exhausted all of the SSRIs.
Okay. And what would be, I know you mentioned like 5 different SSRIs. Which one
Yeah.
is your go-to to start with? Or how would you decide between 2 people to start them, one on, let's say, escitalopram and the other on sertraline?
Yeah, I don't, I try not to have a go-to, because really you just don't know. Everyone is different. And that's why we have so many SSRIs. You're like, oh no, it's crapshoot. I'll throw out sertraline, then that person doesn't respond well to it. So I don't know,
Yeah.
try escitalopram. But I will say that I will give some thoughts around how they all act. So Prozac is really long acting. And sometimes I like that because I'm like, okay, if this is a person that's sensitive to feeling like whenever they don't take a medication, they feel that withdrawal, or they're like, you have those patients who are like, oh yeah, I missed my dose in the morning and I could tell I missed the dose. Um, those patients might do better with Prozac because it's really long acting, so it's kind of going to auto taper, in that once their menses starts and they stop taking the medication. It's going to last for several more days in their system and auto taper. Uh, Paxil, on the other hand, is really short acting. And for some people, that's great because, they take it for a few days before their period, they stop after, it's gone, it's out their system. But some people are going to feel that, like, I took it and now I'm not taking it more than others. And so
Mm,
like my more anxious patients, I probably won't give Paxil because they probably notice it more. So, they're anxious around taking drugs is what I mean, like
yeah,
anxious idea, like, oh my gosh, I got to take this and I don't know, is this going to do to my body? Am I going to be addicted to it? They're the people that feel every little twinge
right.
and side effect. And, you know,
Yeah.
so
My
I'm like,
inbox is full of people with a few of those side effects, and I'm like,
yeah,
be
yeah. And
careful.
then sertraline and escitalopram are in the middle. They're just kind of our tried and true regardless. And whether to choose sertraline or escitalopram is really no rhyme or reason there.
And we use Paxil. I use Paxil all the time for perimenopausal and menopausal patients who might not be good candidates or don't want to use hormones but have really bad hot flashes. Um,
Yeah,
it works really well for them.
yeah,
Um, but I know the weight gain with the Paxil can
yeah.
be, what do you counsel for weight gain?
Yeah, so weight gain, you know, so when it comes to weight gain, I would say sertraline and escitalopram are more weight neutral. Of course, everyone's different, and that's what I tell my patients. I'm like, everyone's different, so you just pay attention. Has your appetite increased? Do you feel like your weight is increasing? Have you had any appetite changes with the weight increase? I just tell them to look out for that from day one. But you definitely tend to see a little more with Prozac as well as or fluoxetine, as well as paroxetine. With spot dosing, you should not be seeing a lot of weight gain.
Okay, and how about with luteal phase? Would that be similar or?
Luteal phase is spot dosing or dosing when symptoms onset. So that shouldn't cause they won't shouldn't be taking it long enough for it to cause any type of weight gain.
Great. I know we have oh, I had one more question and then I know we have a few minutes, but
Mhm.
is there any risk of treating someone, let's say you don't do a chart and you don't officially diagnose your patient with PMDD. Is there any risk of treating someone with really bad PMS the same way you treat PMDD?
No, but I feel like I mean, really, because really bad PMS might be PMDD. Um, I do think it's helpful to get that mood chart though, because you want to get a sense of, and the mood charts not only have depressive symptoms and anxiety symptoms, they also have manic symptoms on there. And so you just want to make sure that you are, at least treating something that's not possibly in the bipolar spectrum. So,
Got it.
but
Yes. And if someone hasn't, if any of our audience haven't joined in the past, Dr. Clark has a specific focus and expertise on bipolar, so is also, I think, much more attuned to
yeah.
that risk. Um, One of the questions from the audience was, how do you feel about intermittent SSRI? I think you kind of answered that, but it sounds like you're open to it. And
Yeah, no, intermittent SSRIs are fine. Again, I just encourage to try to tease out either as they're doing the intermittent SSRI, which is spot dosing or similar to dosing with symptom onset. Um, just encourage that, you're looking for, is this treating the symptoms or do they also have the symptoms the rest of the month? In which case you just encourage them to just take it, just keep taking. Um,
do you
but
ever have someone take a, like, let's say, escitalopram daily, and then
Mhm.
towards in the luteal phase, increase the dose?
Hmm. Yeah, absolutely. So definitely people who they are still sensitive to that premenstrual worsening of mood or anxiety, but they also have underlying depression or anxiety disorder. So yeah, definitely tell them to increase it around that time, and that can be very effective.
Great. I know I want to get to this last question, but we had two questions. One was a citation for the study that showed that SSRIs are more effective than OCPs. It's hard for me to pull it up right now um, while I'm hosting, but we are moderating, but we can find that and send it out with the recording unless you have it on file. And then
I'll
so,
send you guys one. There's many, but I'll put one in the chat right now. Just this is an overview of kind of all the treatments and different things. So
perfect. And then a mood tracking chart, if there's one that you use in particular that you can share, and we can always send that out. Our question to end on is, how do we feel about root cause analysis or hormonal testing instead of symptom management? I have a take on this, but I'd love to
I
hear
think
your
I'll
take.
let you go. I mean, I have a take on it too. You go first. I'll send this. I'm trying to put
Sure.
this.
I think the root of it is currently in our science, we are not at a place where hormonal testing is going to tell us anything, because really someone could have, our hormones are constantly fluctuating, and it's not like this level of estrogen and this level of progesterone always leads to these symptoms in people. I think in Dr. Clark's field, there is much more research now to understand why are some people more sensitive to these fluctuations than others. And I think hopefully in the next 10, 20 years, we'll probably sooner, in the next 10 years, we will have a better understanding of potentially receptors um, that make people more sensitive to these mood changes from those hormonal fluctuations. So I always tell my patients, I don't need to do hormonal testing to
Mhm.
treat you and to tell you that there's something going on.
Absolutely. think you said it all. So I had a patient who actually was adamant about me checking her levels, partly because she disagreed. I believe she had premenstrual exacerbation. She believed she had clear PMDD. She wanted to check levels to prove it. And I was like, the levels, they're actually not consistent enough for us to do anything. We don't have enough science, as you mentioned, and we don't have a way to test what they believe may be a biomarker. This is still in the works. So, so I was like, yeah, we can't do that. I'm basing it on how how she mapped her symptoms for like three, four
Yeah.
months. Yeah.
And what I do believe, I think you and some of your colleagues are doing a lot of incredible work to better understand this. I mean, I always like to remind people women were included in studies in the US starting in the 1990s, right? We
Right.
have a lot to catch up on. And as we start understanding, I see this with menopause all the time, as we start understanding how women are physiologically different, how our hormones affect the other organs in our body aside from the uterus and the ovaries and the brain, we realize that there's so much more nuance and so much that we have to learn. So hopefully one day.
Absolutely. Well, I answered, put those links in the
Thank you.
Q&A for anyone who was looking for them. I also put them in the chat, but it looks like it's just to our hosts and panelists. So I don't
I
know.
could, you're right. I will send them. I don't know that I'm allowed, I can send them out to, unless you answer on the, let me go to the Q&A.
And
Maybe if
anyone
you, oh, you type the answer so people can look at it in the Q&A.
Yeah, and anyone who's listening, the MacMaster is just one. But in that article I sent, they will name three others that have been validated as well. So you can click on the link and, look them up, or you can see the science behind it, the evidence behind it, and validity. But also you can Google for PDFs for those as well.
Awesome. Well, Dr. Clark, thank you so much for this information today. We packed a lot in 30 minutes.
As
Um,
always.
Yeah, as always, yes. And to the audience members who joined us today, we hope you found these 30 minutes engaging and informative. A reminder that we're seeing patients for Seven Starling in Texas, Virginia, Maryland, DC, and New York. We also accept many insurances, and you can always get more information. Or if you want to subscribe to our newsletter, you can email practices@sevenstarling.com. We are committed at Seven Starling to providing you the full spectrum of women's mental health care and would love to support you and your patients. Feel free to check out our website at sevenstarling.com to learn more. And if you liked this webinar, please subscribe to our newsletter so we can keep you informed about future events. We'll send out the recording. We'll have it in the newsletter. Have a great night, everyone. Dr. Clark, thank you so much for